Strabismus or sequent is one of the most important subjects in ophthalmology, especially during childhood. In this lecture, we are going to discuss the definition of strabismus, what are the types of strabismus, few notes about binocular single vision and corresponding retinal point, as binocular single vision is the most important aim in our management. Then what are the signs and symptoms and what are the tests used in diagnosis of strabismus? And lastly, in this lecture, we are going to discuss the treatment for sequent with different types. Early in life, when both eyes are straight and there is no deviation, so any object stimulated both foveae is projected by the central nervous system as it is located in the center of the visual field. And any object like this triangle that stimulate the temporal retina of the left eye and the nasal retina of the right eye is perceived by the central nervous system as it is located on the right side of the visual field. And any object, for example, this object A, rectangular in shape, that stimulate the temporal retina of the right eye and nasal retina of the left eye is perceived by the occipital cortex, by the central nervous system, as it is located to the left of the visual field. This is the basic requirement for binocular single vision and corresponding retinal points, that each point in the right retina corresponding another point in the left retina, and those 2 points, for example AR and AL, sending the impulses to one area in the occipital cortex. This system is usually developed during the first few years of life, especially the first 2 years of life, and it might reach the age of 9 years. For this reason, any patient, any child with sequent should be treated, should be corrected before age of 9 years. And it is preferred to be corrected before age of 2 years to restore binocular single vision. Because this object is located in the center of the visual field, so it stimulates both foveae, and those 2 foveae regarded as 2 corresponding retinal points and perceived as one object in the occipital cortex. There is a superimposition of the 2 images from 2 retinae into one image in the central nervous system. This imaginary line that connecting the object of regard to the fovea is called visual axis. And here we have another visual axis. So normally both visual axes, this one and this one, is usually intersect at the object of regard. When there is a deviation of the eye, for example, there is right convergent sequent or right esotropia. So this red object by visual axis stimulate the left fovea. Here there is deviation and the right fovea is stimulated by another object. This is the triangle, black triangle. Because those are 2 corresponding retinal points, so there is superimposed of 2 different images into one image in the central nervous system, and this is called confusion. Sometimes, also here in this example, we have right esotropia or right convergent sequent. So the red object stimulates the fovea of the left eye because the left eye is straight. But this red object is stimulating another area on the nasal retina because the eye is deviated. So one object stimulated two non-corresponding retinal points. And this point, because it is located on the nasal retina, so it is projected in the central nervous system as it is coming from the right of the visual field. For this reason, there is a diplopia. So patient with sequent complaining either confusion or diplopia. But this is usually occur when there is a good development of binocular single vision, and this is usually occur after age of 9 years. If the sequent is occur early in life, before the age of 9 years, usually the child with sequent doesn't complaining any confusion or diplopia because there is ignorance from the central nervous system to the image coming from sequenting eye. So there is neither confusion or diplopia. So if the strabismus is left without any treatment, without management for a long time, so there is continuous suppression and ignorance of the central nervous system, of the occipital cortex to the image coming from deviated eye, and there is poor visual acuity in this eye, which is called amblyopia, strabismic amblyopia, or lazy eye. And by this way, we are going to lose the advantages of binocular single vision, which are, first of all, fine stereopsis, uses both eyes simultaneously with good visual acuity, we can get a sense of depth. There is a summation of visual field of both eyes into one visual field. Also, the visual acuity become better than using one eye. Other advantage of using both eyes simultaneously when there is an optical defect in one eye, for example, cataract. This can be compensated by the image of the other eye. The other advantage of binocular single vision when there is a visual field defect in one eye. This visual field defect in one eye can be compensated by other normal eye. And also we can leave one eye as a spare for long life because any trauma to the other eye might lead to blindness if the first eye is already amblyopic or lazy eye. For all these benefits of binocular or advantages of binocular single vision, so the first aim from treatment and management of child with sequent is to restore binocular single vision. And for this reason, management and the treatment for any child with sequent should be as early as possible to restore the best quality of binocular single vision. And the second aim is cosmetic. So for distant vision or for near or intermediate vision, the two visual axes usually should be intersect at the object of regard, and any misalignment of visual axes is called sequent. Sequent or strabismus can be classified into three types, mainly three types. Either it is pseudo strabismus or a true strabismus, which is either latent or it is called heterophoria, or manifest strabismus, which is called heterotropia. And heterotropia can be of two types, either concomitant or comitant non-paralytic, and the second one is incomitant or paralytic strabismus. In the following slides, I will discuss and I give you examples of each one of those 5 types. Manifest strabismus or tropia can be defined as strabismus which is seen when both eyes are open, like in this patient. And according to the direction of deviation, we can classify the tropia into 4 types. This is called esotropia, exotropia, hypertropia, hypotropia. In a previous slide of tropia, the angle of deviation is large, so it can be diagnosed even by inspection. But if we have patient with suspicion of tropia, or there is very small angle of deviation, so we should diagnose tropia by cover test. Cover test is done by using a very interesting and small object, but not light, not torch, to stimulate the foveae of both eyes, and then we put a occluder, for example, here to the left eye first, and we are looking to the right eye. If there is any corrective movement to take fixation, it means there is a tropia. Then we occlude the right eye and we are looking to the left. If there is any movement, it means there is tropia. So normally, when we occluding either eye, there is no corrective movement of the other eye. This is just example for cover test. So if we occluding, for example, in this patient, we occluding the right eye here, there is movement of the left eye from outward inward to take fixation. It means this patient has left exotropia. If the cover test is negative and there is no tropia, then we do cover and cover test. So we cover one eye, for example here the left eye. After the cover, there is deviation of the left eye, either inward or outward. In this case, there is deviation of this eye outward due to interruption of fusion compartment of binocular single vision. Then just when we remove this cover, you can see there is a corrective movement of the eye to restore the normal position. This is called phoria because the strabismus is not seen when both eyes are open, like in tropia, and deviation is just seen when there is interruption of a fusion compartment of binocular single vision. Put in your mind that this problem is very common problem, and according to the direction also we have 4 types: esophoria, exophoria, hyperphoria, hypophoria. But the exophoria, like in this example, is the most common one. Put in your mind, there is a 90 to 95% of general population, they have exophoria. And usually it is a symptomless unless the angle of deviation is very large, then it can cause astenobic symptoms, for example, ocular pain, headache, especially during near work. Another example for cover and cover test. So you can see here, there is no deviation when both eyes are open. So it is not tropia. Then when we put a cover for the left eye, you can see there is deviation of the eye behind the cover due to interruption of fusion compartment of the central nervous system. Then just when we remove the cover, you can see there is a corrective movement. The eye is moved from the outside to inside to take its fixation again. So this is called left Exophoria. If we do the same test for the other eye, which is the right eye, and we are occluding the right eye, also in a primary position, there is no deviation, there is no tropia, there is no manifest sequent. And just sequent is seen when we cover one eye. So there is deviation of this eye behind the cover. And just when we remove the cover, there is corrective movement in this direction to take the fixation again. So this is phoria, not tropia. Why? Because first of all, in primary position, there is no manifest sequent, tropia is not seen. Then when we cover the left eye, there is no corrective movement of the right eye, and here when we cover the right eye, there is no corrective movement of the left eye. The left eye is the same, the right eye is the same, and just the eye behind the cover is deviated. And then if we remove the cover, there is corrective movement. So this is called phoria, not tropia. As I mentioned before, manifest sequent or strabismus tropia can be divided into two types, either comitant or incomitant. For example, here, this child has left esotropia. If you ask this child to look to the right, which is called dextroversion, so there is full ocular motility, and to the left, levoversion, also there is full ocular motility, and the angle of deviation is equal in all directions of gaze. So this is comitant sequent, and you should refer this child for ophthalmic department. This is the second type of manifest strabismus or tropia, which is incomitant or paralytic. So here you can see also there is left exotropia. If you ask this patient to look to the right, there is full ocular motility. But to the left, because there is left abducent nerve palsy, there is limitation of abduction of the left eye, and the angle of deviation is large. So if there is limitation of ocular motility and the angle of sequent is varied, for example, here you can see the angle, but in this direction there is no sequent at all, and the angle become largest toward the paralytic muscle. So this is incomitant or paralytic sequent, and you should refer this patient to the neurological department for diagnosis and to reach the diagnosis. And if the cause is a permanent cause, there is no hope for spontaneous recovery of sixth nerve. So then you can shift your patient to ophthalmic department for surgical correction. Surgical correction should be delayed till 6 months to 1 year, till there is no hope for spontaneous recovery. This child has apparent sequent due to wide epicanthic folds. These folds covering the nasal part of sclera, so it gives the observer a false impression of esotropia. But we should not say this is a pseudo-sequent just by finding wide epicanthic fold, unless we do cover test to exclude tropia, cover and cover test to exclude phoria, visual acuity to exclude amblyopia, refractions to exclude hypermetropia or any other refractive errors, anterior segment and posterior segment examination to exclude any ocular disease, then we can say this is a pseudosequent. The other cause for pseudoesotropia is shortening of the interpupillary distance. This distance from the center of pupil to the center of the pupil. And if this distance is less than 50 millimeters, it can give a picture of pseudoesotropia. Another example of pseudostrabismus for this child. So there is an apparent right exotropia, but if we do cover test, there is no any corrective movement of the other eye. If we do cover and cover test, there is no deviation of the eye behind the cover. His visual acuity is normal. He has no refractive errors. He has no any ocular disease. So why there is apparent exotropia in this child? Because the interpupillary distance is large. And usually this is seen when the interpupillary distance more than 65 millimeters. Symptoms of strabismus in early life or during childhood is usually presented by parents rather than by the child himself. So usually they mention that there is a deviation of one or alternating deviation between both eyes, and also they notice that one eye having poor visual acuity or amblyopic eye. Other symptoms are only present after development of binocular single vision. I mean after age of 9 years, which are double vision, difficulty in reading, ocular pain, headache, and fluctuation of visual acuity. So in ophthalmic department, we are concerning with comitant sequent. And according to the direction, the most common, the most frequent type of comitant sequent according to the direction is esotropia. Esotropia in children can be of three types. And before I discuss the types or causes of esotropia, we can divide esotropia into two types, accommodative and non-accommodative. To understand the accommodative esotropia, I should discuss for you what we mean by near reflex. Near reflex means any reflex to visualize any object in a distance less than 6 meters. For example, during reading. During reading, we have three synchatic movements, which are accommodation by contraction of ciliary muscles, meiosis of the pupils due to the contraction of a smooth muscle, circular muscles of the pupil, and also contraction of both medial recti muscle to induce convergence. So when any movement occurs, is usually the other two occurs by stimulation through the central nervous system. There is a normal relationship between accommodation and convergence. For each one diopter of accommodation is usually associated with 4 to 5 prism diopters of convergence. For example, to be read at a distance of 1/3 of meter, usually we need 3 diopters of accommodation. So this 3 diopters of accommodation is usually associated with 12 to 15 prism diopter of convergence. This is occur in normal child and even in normal persons. But when the child, for example, having excessive hypermetropia, because all children usually delivered with hypermetropia less than 3 diopters due to the shortening of the anterior-posterior diameter. So I mean by excessive hypermetropia, hypermetropia which is more than 3 diopters. For example, 4, 5, 10, and even more than 10. So the child, he tried to correct hypermetropia by his accommodation. For example, if we have child with hypermetropia 6 diopter, so 6 diopter multiplied by 5, so he need 30 prism diopters of convergence, and this induce esotropia. The other cause for accommodative esotropia in children is high relationship between accommodative convergence to accommodation. And instead of 1 to 4 to 5 is 1, for example, to 8. For each 1 diopter of accommodation, there is 8 prism diopters of convergence. And for this reason, also the child can be presented with accommodative esotropia, especially for near. And we have a third type of children. They have both of them. They are hypermetrop, excessive hypermetropia, in addition to the high AC over A ratio, which is called mixed. All the three causes, all the three types of accommodative esotropia usually corrected by glasses. This boy has left concomitant accommodative esotropia due to excessive hypermetropia. His strabismus is completely corrected by glasses, and there is no any rule for any type of surgical correction, neither for sequent or for his hypermetropia in this age, and there is no need at all, and the surgery is not an alternative. The only way to correct his sequent is glasses, and the hypermetropia will decrease with advancing age, and usually they reach emetropia at age of 14 years of old. Then they can get rid of their glasses without any sequelae and without sequent. Another example of concomitant accommodative esotropia of the right eye due to excessive hypermetropia, and as you see, her sequent is corrected completely by glasses. So again, this is accommodative refractive type of esotropia, and there is no need for any surgery. This child has concomitant intermittent esotropia due to excessive or high AC over A ratio. This child is presented just for esotropia in near, but the eyes are straight for distance. So he needs glasses, bifocal glasses. The upper segment, this segment, power is 0 because there is no sequent for distant. But here in the lower segment, we put power, for example, +3 for near to avoid esotropia in near vision. And also similar glasses can be used for mixed type. I mean when there is excessive hypermetropia, so we can put here the power. Instead of 0, we can put here a plus spectacle to correct hypermetropia. And we add more than this power by 3 diopters in the lower segment to avoid esotropia for near. So bifocal treatment is used for high AC over A ratio and also for mixed type of esotropia. This boy has alternating esotropia. So can see in this picture, he fixates by the left and the right is deviated. and in this photo he fixates by the right and the left is deviated. For this reason, there is no amblyopia, because suppression and ignorance of the central nervous system is not dominant or persistent on one eye. The suppression is also alternating between both eyes. For this reason, the visual acuity for this boy, because he has alternating esotropia between both eyes, is good, and the visual acuity is 6.6. But our aim in management, you should remember, our aim is not to get visual acuity 6.6, is to restore binocular single vision. I think the age for this boy may be 7 or 8 years, and the sequence is not corrected. So this boy lost the first aim, which is binocular single vision, because there is no simultaneous perception of vision and there is no normal correspondence of retinal points. This is a neglected case of alternating exotropia since childhood. And the visual acuity for this man in both eyes is 6.6 in both eyes, because the sequence is alternating. Definitely, this man, he has no development of normal binocular single vision, because as I mentioned for you before, usually this system is developed before age of 9 years. And now this man, he got abnormal retinal correspondence. For example, the fovea now of this eye is corresponding another point on the temporal retina of this eye, and this is since childhood. So any correction, any surgical correction just for cosmetic purpose might induce diplopia, and the surgery is contraindicated in this age. This is another reason why we should do a surgery as early as possible. This boy has left monoocular esotropia. The fixation is almost always by the right eye, and the left eye is almost always deviated. For this reason, there is poor visual acuity in this eye, because the suppression and the ignorance is persistent for the left eye. The sequence is not alternating, monoocular. So, to improve the visual acuity in this amblyopic eye, we should occlude the normal fixated eye to stimulate the central nervous system by the left eye. And this is the treatment of amblyopia by occlusion. Occlusion of the eye for long period can induce a more danger amblyopia to this eye, which is called deprivation amblyopia. For this reason, there is timing for occlusion, that we can occlude the eye for 1 week per year of age. For example, if the age of this boy is 3 years, so you cannot occluding the right eye more than 3 weeks. Otherwise, it can lead to amblyopia of the right eye. The other type of comitant esotropia is non-accommodative esotropia. And we have many causes for non-accommodative esotropia, but the most important one for you as a first day doctor in future is congenital esotropia or essential esotropia. It means that the infant or child is delivered with esotropia, or esotropia developed during the first 6 months of life. The criteria for this type of esotropia is large angle with a cross fixation. So he can, because the angle is very large, so he can fixate objects on the left side by right eye and objects on the right side by the left eye, and there is no need for abduction of both eyes. For this reason, one of the most important differential diagnoses for this type of sequence is bilateral sixth nerve palsy. Usually, the refraction is normal with their age. I mean, they usually have hypermetropia less than 3 diopters, and there is normal AC over A ratio. And if we examine them with normal anterior segment and posterior segment, so here the most common treatment is surgical treatment because there is no associated refractive error or high AC over A ratio. And as I mentioned for you, surgery should be done as early as possible to restore the best quality of binocular single vision. Those are two cases of essential or congenital esotropia. You can see the angle is very large angle, and although very few cases can be corrected by glasses, so we should do refraction, but usually the refraction is normal. But if there is any refractive error, also should be corrected. Otherwise, surgery is indicated for most of the cases with congenital esotropia. For any child with sequent, we should take a full history, then examination of visual acuity, examination of refractive state, then examination of anterior segment, and also examination of the posterior segment. So one of the diseases which can lead to macular damage is congenital toxoplasmosis that involving the macula. So this child with poor visual acuity can present it with sequent. So sequent can lead to poor visual acuity and amblyopia, and poor visual acuity also can lead to sequent. So fundoscopy is important for all children with sequent. The most common causes of leukocoria, white pupil, in children is congenital cataract and a very serious primary tumor, a fatal tumor of the retina, which is called retinoblastoma. Those two diseases, congenital cataract and retinoblastoma, the usual way of presentation is leukocoria, white pupil. But the second way of presentation is sequent. This is again an example to examine the anterior segment and posterior segment for all children presented with sequent. Surgical treatment for esotropia is by weakening of medial rectus muscle and strengthening of lateral rectus muscle. Weakening of the medial rectus muscle is by recession of the muscle. We disinsert the muscle from its original insertion. This is the origin of this is the insertion, original insertion of the medial rectus muscle, and then we resuture the muscle more posterior, and by this way we do weakening of the medial rectus muscle. So it might be enough to correct sequent just by weakening of medial rectus muscle, and sometimes we need both of them, weakening of medial rectus muscle and strengthening of the lateral rectus muscle. This slide is again for weakening or recession of the muscle. This is the conjunctiva. We open the conjunctiva and then the tenon capsule, and we exposed the extraocular muscle, and then we disinsert. This is the original insertion of the muscle. We cut the muscle from its origin and then resuture the muscle more posterior, This is 5 or 6 or 7 or even 8 millimeter according to the degree of sequent, but we should not go posterior to the equator because the action of the muscle become in opposite direction. And this is the strengthening or resection of the muscle. We open the conjunctiva, then we disinsert the muscle from its normal insertion. This is the normal insertion. Then we cut part of the muscle, resection, and then resuture the muscle in its normal position. By this way, we do shortening of the muscle, and this leads to strengthening of the muscle. Resection might be done in one eye or in both eyes. It depends on the degree of deviation. This is the last slide for this lecture. Just I want to mention very important subject, that children with cerebral palsy can be presented also with strabismus, and many people, they make a relationship between their sequent and cerebral palsy, and they told them you have no treatment. The type of sequent in those people is usually concomitant sequent, which is not related, not paralytic, not related to the cerebral palsy. And we should deal with those people as we are dealing with normal children. So just in cerebral palsy, the incidence of sequent is more, but there is no direct relationship between sequent and cerebral palsy. Thank you very much for your attention.